FGF23 is a hormone that doesn't always get the spotlight that it deserves in CKD. I like to think of FGF23 as the body's phosphorus traffic cop, and its job is to keep serum phosphorus levels in check.
Hello, everybody. Welcome back to this episode sponsored by DECRA and featuring Dr. Chris Byers. It's been a long time since we've had the chance to talk, so I was really happy to welcome him back on the podcast. And we got to dig into one of my favorite topics, which is chronic kidney disease in cats. Now, not only do I find this condition really fascinating in terms of management and pathophysiology and all that good stuff, but I also think it is kind of one of those conditions that can be really rewarding to manage. And there's been so much new research, treatment, updated recommendations in the past few years. I mean, such an exciting time for advances when it comes to managing chronic kidney disease. So in this episode, Dr. Byers and I focused mostly on phosphorus in particular. And I mentioned at the beginning of the episode, I'm curious to know if I'm unique in feeling this way, that sometimes it seems to me like phosphorus, it just kind of gets lost in the mix when it's still within the normal reference range. We have so much we're trying to monitor in these cats, and creatinine, SDMA, BUN, urine-specific gravity, proteinuria, blood pressure, calcium, that when that phosphorus stays in the normal range, it sometimes just takes a back seat to all of these other factors. So this was a good reminder about why phosphorus deserves our early attention. Even when it's normal, as it starts to creep up, it can act as a disease accelerant and work against our efforts to keep CKD under control in the long term. And now we have some new options to help manage it more effectively. So we got into both monitoring and management strategies that can make a big difference in our feline patients with chronic kidney disease. If you don't know him already, let me go ahead and introduce Dr. Chris Byers, and we will get into our talk. Dr. Christopher Byers is a practicing dual board certified veterinary specialist, recognized international speaker, and respected author. Dr. Byers enjoys reading and is passionate about helping pet parents understand their fur babies' health problems. He launched criticalcaredvm.com to provide dog and cat owners with high-quality, accurate, and comprehensive information they need to understand their pet's health problems. Since 2014, the information available at criticalcaredvm.com has been extensively used by pet parents and veterinarians alike, helping Dr. Byers realize his primary goal, promoting the triad of care, a collaborative partnership between pet owners, primary care veterinarians, and board-certified veterinary specialists. Really such a great speaker, full of a ton of helpful information and just delivers it in a very digestible way. Let's go ahead and get into our episode.
Nutrition is the cornerstone of our patients' health and happiness. The veterinary healthcare team should be the ultimate source for top-notch pet nutrition info. When clients see how the right diet helps their pets stay healthy and happy, they visit us more often. Remember, good nutrition is essential. It's smart business and great medicine. Enroll in the NAVC Pet Nutrition Coach certification today on vetfolio.com.
This is such a great way to start my day here talking to Dr. Chris to talk about kidney disease in cats. It's so interesting with some of the new data and products that we have out there. So Dr. Byers, thank you for joining me.
Thanks for having me back. It's always fun to chat with you, and this is a great topic that always deserves review.
Absolutely. Absolutely. I know as we were kind of chatting through talking points, I know you and I were both agreeing that it seems like every talking point around CKD in cats is just kind of a beefy topic in and of itself, that there's just a lot to say. So I'm excited to dive into it.
Absolutely. Absolutely.
We're going to focus on hyperphosphatemia in particular because this is such a beefy topic and needs to be narrowed down for conversation's sake. So this can be one of those, I know at least for me, watching BUN, creatinine, SDMA, specific gravity, proteinuria, blood pressure, things like that. And then we've got phosphorus hanging out over here, and something we need to be watching really closely and making sure that we're intervening with phosphorus. But I don't know, sometimes I feel like it can get a little bit lost in the shuffle. So can you talk with us a little bit about some of maybe the pathophysiology behind hyperphosphatemia with CKD and what we're looking for, why it's important to continue to monitor that?
Sure. I really like to think of phosphorus management in CKD a little like crowd control at a busy concert. In a healthy cat, the kidneys are the security team, quietly maintaining order by, filtering out excess phosphorus and keeping serum levels within a narrow range. And, so under normal physiology, dietary phosphorus is absorbed in the small intestine and the kidneys excrete the surplus. And this balance is tightly regulated through a network of hormonal signals involving parathyroid hormone, calcitriol, and fibroblast growth factor 23, or FGF23. But in chronic kidney disease, nephron loss and declining glomerular filtration rate reduce the kidney's capacity to excrete phosphorus. So imagine our security team losing members one by one. Too many guests, in this case phosphorus molecules, are allowed to linger. So serum phosphorus levels begin to rise, even if the patient's dietary phosphorus intake hasn't changed. Now, the body's first compensatory move is to call in FGF23, released from osteocytes in bone. And FGF23 works in two ways. One, it increases phosphorus excretion per remaining nephron. And two, it suppresses renal production of calcitriol by inhibiting 1-alpha hydroxylase activity. So, reduced calcitriol means decreased intestinal calcium absorption, which leads to mild hypocalcemia. But this in turn stimulates PTH secretion, parathyroid hormone secretion. That's the start of secondary renal hyperparathyroidism, because PTH tries to normalize calcium by increasing bone resorption, releasing both calcium and phosphorus into circulation. But unfortunately, that further adds to the phosphorus load. So over time, this feedback loop becomes maladaptive. So persistent hyperphosphatemia and high calcium phosphorus product promote soft tissue mineralization, including within the kidneys themselves, which accelerates renal injury. Think of it as lime scale building up inside already compromised plumbing. The narrower the pipe gets, the worse the flow becomes. And the consequences go beyond the kidneys. Elevated phosphorus and sustained hyperparathyroidism contribute to muscle wasting, osteodystrophy, and honestly, systemic malaise. And these changes directly impact patient comfort, function, and longevity. So, long story, really short, phosphorus in CKD transitions from being a background mineral to a key driver in disease progression. So in a way, understanding its pathophysiology really reminds us that controlling phosphorus isn't just about achieving a lab target. It's really about disrupting a destructive cycle and preserving both renal function and quality of life.
You really drove it home there. That made a lot of sense. And I always get so excited when we talk internal med and these different pathways, because it's so interesting. So we start to see this increase in phosphorus and get the release of FGF1. And that's going to reduce intestinal absorption of calcium, which is going to be the start of renal secondary hyperparathyroidism, because PTH is now going to start increasing to try to increase these calcium levels, which is in turn going to exacerbate the hyperphosphatemia. and lead to, like you said, inappropriate mineralization and further loss of function throughout the body, both in the kidneys and other areas of the body, which is not only going to have physical implications, but those physical implications are going to make our patients also just feel really crummy.
Yeah, it does make them feel really crummy.
Did I follow that pathway correctly?
The only tweak I would make is that FGF23 is going to go up before hyperphosphatemia sets in.
I see. Okay. And I'm glad you said that. I don't know why I said FGF1, FGF23. I don't know where my brain went there for a second. And I'm glad that you said that, because that was kind of going to be my next question of if FGF23 is going to rise before we see clinical hyperphosphatemia or laboratory hyperphosphatemia, like how do we think about monitoring phosphorus in these patients?
Yeah, great question. So for me, this is a great moment to make sure that listeners are familiar with FGF23. FGF23 is a hormone that, in my opinion, doesn't always get the spotlight that it deserves in CKD. I like to think of FGF23 as the body's phosphorus traffic cop. It's a hormone produced mainly by osteocytes and osteoblasts in bone, and its job is to keep serum phosphorus levels in check. So when phosphorus starts to creep up, not necessarily outside of a reference range, but when phosphorus just starts to creep up, bone cells release more FGF23 into circulation. And FGF23 has two main effects. So one, in the kidneys, it reduces that phosphorus reabsorption in the proximal tubules, which increases urinary phosphorus excretion. Two, in vitamin D metabolism. So it's inhibiting that enzyme 1-alpha hydroxylase, which reduces calcitriol production. So again, what does that mean? Less intestinal calcium and phosphorus absorption, which indirectly helps lower serum phosphorus, but also has implications for calcium balance. So here's where it gets, in my opinion, interesting for cats with CKD. In the early stages of the disease, even before phosphorus rises above the reference interval, FGF23 often increases. And this is the body's attempt to compensate for reduced nephron capacity. So measuring FGF23 can give us a head start in identifying phosphorus dysregulation before overt hyperphosphatemia develops. So a normal FGF23 suggests phosphorus homeostasis is intact, at least for now. Even in CKD cats, a normal value means dietary phosphorus restriction might not need to be aggressive yet, though the stage of disease and other parameters are still going to guide decisions. But an elevated FGF23 with normal phosphorus is your early warning sign. The kidneys are already struggling to excrete phosphorus, and bone is signaling that compensation is underway. This is often the stage where dietary phosphorus restriction can be implemented to prevent overt hyperphosphatemia, to delay secondary renal hyperparathyroidism. Now, if you have an elevated FGF23 with hyperphosphatemia, we know compensation has failed. This is the patient who needs more intensive intervention, dietary restriction, plus phosphate binders if diet alone isn't controlling serum phosphorus. And then I'd say lastly, a persistently high FGF23 despite therapy suggests our phosphorus control strategy isn't fully effective. Either, the diet isn't low enough in phosphorus, binding dosing isn't optimal, or a compliance issue is taking part in what's going on. It can also indicate, of course, that there's ongoing disease progression despite everybody's best efforts. So let's make sure that we appreciate the clinical relevance. Let's just make sure that we're all on the same page.
Sure.
FGF23 rises before serum phosphorus does. So it can serve as a biomarker for early intervention. Elevated FGF23 is independently associated with shorter survival times in CKD cats, even after adjusting for phosphorus and creatinine. So it helps tailor treatment, especially in early stage CKD when phosphorus is quote unquote normal, but compensation is already at work. So think of it like this. Phosphorus measurement tells you where the fire is now. FGF23 tells you where the embers are starting to smolder. If we act when the embers appear, maybe we can prevent the fire from spreading. Okay? Now, I also want the listeners to be aware of the International Renal Interest Society, or IRIS, stage-specific targets for phosphorus in CKD cats. So for stage 2, we're targeting 2.7 to 4.6 milligrams per deciliter. Stage 3, 2.7 up to 5 milligrams per deciliter. And for stage 4, 2.7 up to 6 milligrams per deciliter. So if phosphorus is above these targets, intervention is absolutely warranted, regardless of your in-house machines or your reference laboratory's reference interval. But in practical terms for FGF23, if you have a stage 2 CKD cat with a phosphorus of 4.3 and an elevated FGF23, that's your cue to tighten phosphorus intake sooner rather than later. Conversely, a normal FGF23 can give you confidence to monitor closely without over-restricting unnecessarily. The bottom line, measuring FGF23 gives us another layer of precision in CKD management. It's not a replacement for monitoring serum phosphorus, for monitoring calcium, for monitoring parathyroid hormone. It's an early warning, a fine-tuning tool that can honestly help us be more proactive with individualized treatment plans for our feline patients.
So I'm definitely appreciating how important a role FGF23 is playing in that, like you said, an early warning sign and giving us the best opportunity to have successful interventional measures when we're dealing with phosphorus in these cats, which, I'm sure many of us can appreciate. The cats kind of make the rules as far as how this kidney disease is going to progress. So as tight of a handle as we can get on what's going on and intervening at appropriate times, really gives us the best opportunity to slow the progression and the severity of the disease. So should we be thinking of monitoring FGF23 kind of like we monitor other markers like BUN creatinine, SDMA, calcium, SpecRav, blood pressure, proteinuria, things like this?
In my opinion, yes. And I think I said earlier something along the lines that FGF23 doesn't get enough play in our thought process. And if there's one major takeaway for listeners, it's to start thinking about serially monitoring FGF23 just as they would blood urea nitrogen, creatinine, blood pressure, proteinuria, etc.
Sure. That makes sense. I think it also might change the conversation with pet owners. That can certainly be a point of contention when we're talking about dietary therapy to manage phosphorus and feeding a phosphorus restricted diet. I mean, there's a lot of, I don't want to change the food, every reason under the sun. And I think that might help the conversation to maybe with certain owners be able to present here we have a numerical marker to say we need to start thinking about restricting phosphorus in one way or another, because I can show you here before the phosphorus is even elevated where we're headed.
I agree. It's been my experience that pet owners really like to be exposed to objective evidence-based data whenever possible. And by measuring FGF23, you're able to provide that for them. Now, on the other hand, you might have some of those owners that become absolutely number driven, and that poses its own challenges. Sure. But again, what's best for the patient? It's monitoring FGF23 as one of your biomarkers in patients with chronic kidney disease.
Absolutely. Absolutely. And we've talked about, phosphorus restriction via dietary therapy. What are some of the other management options we can think of when we're dealing with either elevated FGF23 or hyperphosphatemia?
Okay. So let's just remember that hyperphosphatemia in CKD, I've said it before, it's just not a lab abnormality. It's a disease accelerant. It fuels that secondary renal hyperparathyroidism. It promotes soft tissue mineralization. It speeds nephron loss. And so our job is to bring phosphorus back into the therapeutic range and keep it there. So we really want to remember those IRIS guidelines for phosphorus control that I mentioned earlier. Now, in terms of treatment options, we do have quite a few, and I want to mention a little bit more about dietary phosphorus restriction because it is typically our first line intervention. Prescription renal diets do just that. They typically only contain, somewhere on the order of 0.3 to 0.6% phosphorus on a dry matter basis. And they use protein sources with lower phosphorus bioavailability. So they are the first line therapy when phosphorus rises above IRIS targets, or even earlier if FGF23 is elevated. Okay, the challenge, right, is that some cats won't eat them. And diet alone may not be enough for patients living in later stages of CKD. But I would still say starting with a renal diet is often the most important in keeping phosphorus under control. Then when diet alone isn't enough, we have phosphate binders as a next solid step. And I think most colleagues initially think of aluminum hydroxide. It works by binding dietary phosphorus in the gut, forming, an insoluble compound that is passed in the feces. And it's available as powders, gels, tablets. They're all effective. They are inexpensive in my experience, and they can be mixed with food, although that's not ideal. The main caution with long-term use, we often get to high doses as disease progression occurs. And so aluminum can accumulate and cause problems like microcytic anemia or neurological signs. And so, we just have to be aware of that. And while the risk appears low in cats, at least compared to people, it's always something that I want to keep in mind as we progress through the months and years for patients receiving aluminum hydroxide. But takeaway number 2 for me, for listeners, is that aluminum hydroxide isn't our only option for phosphorus binding. There are several others worth knowing about. And I'll mention first, lanthanum carbonate, like Dechra's Catni-1, is a potent binder that forms insoluble lanthanum phosphate in the gut. It's minimally absorbed, and so there's little risk of mineral imbalance. Number 2, sevelamer. It's a non-calcium, non-metal binder that really swaps chloride or carbonate for phosphorus in the GI tract. So it avoids the aluminum and calcium issues. And at least we know in humans, it even binds bile acids and lowers LDL cholesterol. I don't know if that's been studied in feline patients, but it is something that's well documented in human patients. Now, the downsides, it can cause constipation or GI upset. And we really have quite limited feline-specific research for this supplement. And then we have the calcium-based binders like calcium carbonate or calcium acetate. They're effective, they're inexpensive, but they do carry a risk of hypercalcemia and soft tissue mineralization, especially if the calcium phosphorus product is already running high. We generally reserve them for hypocalcemic cats when the other binders aren't an option. So, with all of that said, let's not lose sight of the forest for the trees. So what's my treatment strategy? Let's keep it as simple as I can. That's the way my brain works. Step 1, initiate renal diet as soon as phosphorus is above the target range for CKD, or certainly if FGF23 is elevated. Step 2, recheck phosphorus 4 to 6 weeks later. Step 3, if you're above target despite good dietary compliance, add in a phosphate binder. And again, I feel most people start with aluminum hydroxide, and I want to say I'm just not aware of any data that says one phosphorus binder is superior to the other. So make sure you're remembering all of the options that we have. Catenine-1, sevelamer, calcium-based binders if they're appropriate. And then step 4 is to titrate those binders to keep phosphorus in range. And so you may need to consider alternatives if there's poor compliance, if there's a lack of effect, or if specific contraindications like hypercalcemia with a calcium-based phosphate binder arises. And then step 5, regular monitoring, typically every 4 to 8 weeks during adjustment. And then once things are status quo, stable, every 3 to 6 months. So remember that phosphorus control, it's about more than just hitting a number. It's about slowing CKD progression, minimizing secondary renal hyperparathyroidism, improving quality of life. So in CKD cats, think of phosphorus like water dripping into a bucket with a crack at the bottom. Your remaining nephrons are the crack. And as the hole gets smaller, the water level rises faster. Our job is to turn down the faucet with diet. And if that's not enough, use binders to catch the water before it even hits the bucket.
That paints a picture right there. I think that really illustrates it. And I love the step-by-step approach to, this is how we should be considering phosphorus. This whole conversation is making it very just doable to wrap my brain around it and say, okay, this is what I need to be monitoring. This is why, and this is how to approach addressing it when I start to see abnormalities, which is one of the beautiful things about the IRIS guidelines. I feel like the IRIS guidelines do a great job of breaking a lot of this down. And I understand there was a recent update to the IRIS guidelines. I can't remember exactly what year they were updated, but I'm curious about, one, what some of those updates might include, and is this information about FGF1 and managing hyperphosphatemia, has that been addressed in the updates as well?
Wow. We're really going to open that can of worms.
Let's do it. Let's do it. Yes.
Okay.
I mean, that's like my go. I get that CKD blood work back, and I'm straight at the IRIS guidelines going, okay, what stage am I and what am I reaching for at this point, and refresh my memory here.
I love it. I never steer from controversy. So let me just say, when it comes to managing our feline CKD patients, one of the biggest traps we can fall into is relying solely on the reference ranges printed on our lab reports. They're useful for screening healthy patients for sure, but they are not best practice for staging CKD or guiding therapy. And that's where IRIS comes in. IRIS guidelines are robust evidence-based guidelines that give us stage-specific targets for both creatinine and phosphorus and SDMA. And obviously, these are all biomarkers that are absolutely central to diagnosing and to therapeutic monitoring. So let's start with creatinine as an example. In a healthy cat, creatinine values will typically fall somewhere in the lab's reference range that may go up to 2.2 milligrams per deciliter, depending on the lab. But IRIS uses creatinine thresholds to classify CKD into stages 1 through 4. And so that means a creatinine of 2.0 still might look normal, quote unquote, to a colleague reading the report. But what I want us to recognize is that 2.0 pushes that patient into stage 2 CKD. And that staging matters because it shapes how often we monitor, when we start phosphorus restriction, how we discuss prognosis. Now, phosphorus is where the difference between lab reference ranges and IRIS targets really becomes critical, in my opinion. Most labs are going to give you a quote unquote normal phosphorus range that's designed for a healthy cat, somewhere like 3.0 to 6.0. The problem is that in a CKD patient, phosphorus at the upper end of that range is not benign. So don't forget those IRIS recommendations for phosphorus management that are based on CKD stage. So imagine you've got a stage 2 CKD cat with phosphorus at 4.8 milligrams per deciliter. The lab report might call that within normal limits, but IRIS would tell you that value is already above the therapeutic target. And that's when you should be intervening with dietary phosphorus restriction or even binders if diet alone won't get you there. So why is there this difference? Lab reference ranges are static. They don't change based on disease stage, and they aren't designed to predict outcomes. IRIS targets, on the other hand, are dynamic. They're grounded in data showing that keeping creatinine and stage-adjusted phosphorus within those narrower ranges slows progression. It reduces that secondary renal hyperparathyroidism, and it extends survival. For me, the other big advantage of using IRIS, consistency. Whether you're in Omaha or Osaka, IRIS staging gives veterinarians and veterinary healthcare teams a common language for diagnosis, prognosis, and treatment. It also honestly keeps us from getting lulled into complacency just because a number looks quote unquote normal on paper. So for me, the takeaway, when you look at creatinine and phosphorus in your CKD patients, don't just ask, is it in the lab's normal range? Ask, is it in the IRIS target range for this stage of disease? That's how we make sure our interventions are proactive, not reactive. And that's how we give these cats the best chance at a longer, better quality of life. Now, the latest cat treatment recommendations for CKD from IRIS include 4 key updates that I want listeners to know about. First, clopidogrel is now the first-line drug for cats with protein-losing nephropathy who are considered at risk for thromboembolic disease. And serum albumin below 2.0 grams per deciliter is no longer used as an automatic trigger for starting therapy. 2, FGF23 is absolutely now part of the picture. Even if serum phosphate is within the iris target range, measuring FGF23 can guide when to start dietary phosphorus restriction, especially in early stage cats, or when to tighten restriction if dietary changes have already lowered phosphate into the target range. Number 3, calcitriol is out for stage 3 and 4 cats. Put simply, there's just not the evidence to show that it provides benefit. And 4, stage 2 cats should be treated for vomiting, appetite loss, nausea, weight loss, or muscle loss, while remembering that SDMA can help with staging in cats with significant muscle loss, and that we should still investigate other possible causes of vomiting.
I love it. This is why, I feel like you just demonstrated right there why I end up at the IRIS guidelines when I see these changes. And I think you brought up some really important points that I want to kind of circle back around to. One is the laboratory reference ranges. And I think this is a really important point to make. One, why it's so important that we have urine samples on our cats, especially as they're getting older and we're monitoring, because we see these creatinine levels start to climb a little bit. But to your point, they can very much still be in the reference range. And so correlating that to the spec grav and some of these other findings, I think can really just give us the picture we need to know what's going on with our patients. Of course, I want to say, qualify that with I love looking at blood work. I think it's super interesting. I really like managing kidney disease. I also think that's really interesting. And so I have all of the empathy in the world for colleagues who are running around in a busy practice and, look at a paper and say, none of those values are highlighted, and maybe don't get quite as excited about it as I do. But I'm wondering, can you talk a little bit about the laboratory reference ranges for starters? For example, if we got a creatinine back on a middle-aged, starting to get up there, feline patient, came back around 2, and we don't have a urine to correlate that with, do you ever see those elevations happen due to hydration status, or would that automatically key you in to say, this is a CKD patient, we need to start watching this more closely?
Great question. So if I see a cat with a creatinine of 2, I am going to start worrying about renal compromise, but I'm going to look at signalment. I'm going to look at patient history, and I'm going to need some additional laboratory data to help me figure out, is this acute kidney injury? Is this prerenal azotemia? Is this intrinsic renal dysfunction that's chronic in nature? So I want to know, is that patient dehydrated? I'm absolutely going to want a urine sample. They don't call urine liquid gold for no reason. There's a reason that we want to look at it. If I document a spec grav of 1063 in a cat with a creatinine of 2, my first concern is going to be prerenal issues as a cause for that 2.0. And I'm not going to just rotely say, well, we've got a stage 2 CKD on our hands.
Sure, that makes sense. And yes, I agree with you with the urinalyses. When you can put that whole picture together, like you said, liquid gold makes a huge difference. And of course, if we did see that 2.0 and a 1063, that would beg other questions to say, what's going on here? On the flip side, can you talk about how you assess maybe muscle scoring in feline patients, and how that affects your interpretation of creatinine if we're dealing with muscle loss as opposed to, say, dehydration that might artificially raise creatinine?
Sure. So if we have a patient with, I'm going to use the 2.0 creatinine again, I'm going to look at that patient, and I am going to do the validated muscle scoring that I hope all the listeners are familiar with. And if that patient has a degree of sarcopenia, if there's a degree of muscle atrophy, I'm going to score it. And that's going to raise proverbial red flags that my patient's creatinine may be falsely decreased because their muscle mass is decreased. So then I'm going to want to look at SDMA. And IRIS does provide SDMA guidelines because of the limitations of creatinine in patients as they lose muscle loss as being as reliable an indicator, as reliable a biomarker for renal dysfunction.
And I love that we're talking about this, and this is why I love looking at blood work, because as much of a relief as it can feel like, especially in cats, when you see nothing highlighted when your lab report comes back, it's the subtle differences just patient to patient and case to case. I think it's really interesting. Like you said, there are limitations. So making sure that we're really digging deep and figuring out what's going on with that individual patient, which sometimes can really create a lot of headaches and be a pain in the neck. But when you are able to catch something early, you say, oh, well, that creatinine is normal, but we have documented muscle loss here. So let me go back and actually review these other values. Oh, look, we got onto this cat early. And so we're hopefully creating a better prognosis in the long run. I don't know. It's one of those really rewarding, like, yes, I figured it out moments.
And you can turn that moment for you as the healthcare provider into a positive moment for the pet owner as well by saying, look what you helped us identify very early. You are being a great owner by being proactive and allowing us to examine your cat. You allowed us to do this. And because of the data that we got from your proactivity, we can now intervene sooner. You've made a difference in your pet's healthcare. And I can't tell you how much I believe that impacts owner compliance. When they feel like they are a active, helpful member of their pet's healthcare team, my feeling, my experience over the past 2+ decades is that they will do whatever they can within their power and their means to continue to be as proactive as they can be, to continue to heed your recommendations as much as they can. So it becomes a very powerful collaborative team for that pet.
Yes, I couldn't agree more. And I think it also strengthens our conversations with other pet owners who, may say, they're doing fine. They don't need blood work. Do you ever actually find anything when you do those tests to say, well, yeah, we do. And to empower you as a practitioner to say, yes, these tests are important, and have that list of cases in the back of your mind where those owners being proactive really did make a difference in the well-being for that patient, helps make those recommendations a little bit stronger for other patients in the future. And really, I think everybody benefits in the long run.
Yeah. So for me, it's those IRIS guidelines are so impactful because really they remind us to think of staging, really as a single snapshot, but as a combination of laboratory data, clinical signs, and trends, underscore, bold, italicize. That's how we catch CKD earlier. And the earlier we act, the better we can slow disease progression.
Absolutely. I feel like that's the perfect place to wrap it up, to just say, the more we can keep an eye on these guys and really be aware of the results that we're getting back and how to interpret those critically, the better off our patients are going to be. Dr. Byers, thank you so much. I always learn a lot it's been so long since I've had the opportunity to sit down with you. I was very excited that you're back on the podcast. So thank you for joining me. Any final thoughts you want to share?
No, I think that I think we've given the listeners a lot to digest, but I think it's not ivory tower stuff. It's in the trenches, practical information that is ready to be taken and shared immediately with their healthcare teams and put into action for these cats living with CKD.
Absolutely. And so thank you again for joining me to share all of it, because I agree. You made it very digestible and very applicable.
Well, thanks for having me back. I look forward to coming back whenever you want me.
Love that. Well, thank you so much to everyone for tuning in. I know that one was a little dense, but I hope you're like me and took away a lot from that episode. Big thank you to Dechra for sponsoring this episode. Chris, always wonderful to talk to you. Thank you so much for coming back on the podcast. And of course, a big thank you to all the listeners out there. Thank you so much for tuning in. If you enjoyed this episode, please leave us a 5-star review wherever you get your podcasts. It'll help other veterinary professionals like you find this and other great content we try to put out there. Of course, we want to hear your input on this talk as well as ideas for topics you'd like to hear from us in the future. So feel free to reach out to me at dvm@vetfolio.com. We can also connect on Facebook at Dr. Cassie DVM, or you can find me on Instagram at dr.cassie.dvm. And remember, if one animal is better off because of you today, it's a great day.